ये नहीं कहे कि डॉक्टर साहब ने बताते हैं आपके बच्चे को दिक्कत हो सकती है, ये नहीं बोल रहा हूँ आज होगी, ये नहीं।
A very good afternoon, everyone. It is my pleasure to welcome you all to the 9th Pediatric TB Eco Clinic in collaboration with the Regional Pediatric Center of Excellence for Tuberculosis. The clinic is dedicated to challenging cases of pediatric tuberculosis. As we all know, tuberculosis remains one of the most pressing global health issues in children and is associated with complexities in diagnosing and treating TB in pediatric patients. On behalf of National Institute of TB and Respiratory Diseases, I extend my warm greetings to our DDG-TB, CTD, Professor Urvashi B. Singh. Dr. Urvashi is a distinguished medical microbiologist at AIIMS and has extensive research experience in the field of tuberculosis. Her leadership and expertise will undoubtedly be instrumental as we continue to confront the global burden of pediatric tuberculosis. I welcome directors and team from NIIT, NTI, STOs, directors of STDCs, faculty of medical colleges, district TB officers, medical officers, TB pediatricians, and everyone present. Without further delay, I would like to now introduce the faculty from NIT RD. I'm Dr. Dhulika Dhingra, specialist pediatrics at NIT RD, and I will be moderating today's session. To my right is Dr. Sangeeta Sharma, ex-director NIT RD, and to my extreme right is Dr. Alok Yadav, CMO NFSG. To my left is Dr. Saroj Meena. She is specialist at NIT RD, Department of TB and Respiratory Diseases. I would now request our director, Dr. Manpreet Bhalla ma'am, to give her inaugural address.
Thank you and good afternoon, everyone. So I welcome you all once again on behalf of NITRD for this 9th Pediatric TB Echo Clinic, which is being conducted today along with Regional Pediatric Center of Excellence. So we have with us today DDG TB, Dr. Urvashi B. Singh, who is always there with a constant support and guidance. We have also Dr. Ashok Bhardwaj, Chairman NTF, who is always present to support us and give his guidance. So as has been told, we have completed this Pediatric TB Eco Clinic has completed 1 year since the start of this clinic, and we have circulated the information and disseminated the information regarding these clinics through emails as well as through eco platforms to all medical colleges, including AIIMS and also PGI Chandigarh, to enhance the participation. So as we all know that pediatric TB diagnosis and treatment are very challenging. These clinics are being held regularly, almost every month, to facilitate all the doctors, as has been told, all the district TB officers, medical officers, the faculty of medical colleges, so that they can interact with the national experts on a common echo platform. And they can address whatever doubts, apprehensions, and all they have with respect to all forms of pediatric TB. So today's case presentation will be done by AIIMS Delhi and by Dr. Sri Shail, who will be talking about challenges in MDR-TB. And he's a DM fellow in pediatric pulmonology at AIIMS. The case expert will be Dr. Kanaram, who is a professor pediatrics, AIIMS Delhi. The national expert is Dr. S.K. Kabra, former head of pediatrics, AIIMS Delhi. So I hand over, thank you very much, and I hand over to Dr. Dhulika for further deliberations. Thank you.
I would now like to invite Dr. Sangeeta Sharma, former director, National Institute of TB and Respiratory Diseases, to give her address and also welcome our DDG TB, Dr. Urvashi.
Thank you, Dhulika. Once again, we are here after exactly 1 month. That is on the third Tuesday, 2 to 3 p.m. with all my colleagues. just to give you a feedback that we are booked for 17 months in a row. So all the centers, they have put in their effort and to make this a success. So without wasting words, I now request our DDG TB, Dr. Urvashi, to give her inaugural address. Dr. Urvashi, please.
Good afternoon, all. Namaskar. And thanks for having me here today. Let me start by every time I like to thank the director NITRD, Dr. Sangeeta Sharma, who has consistently done this, and her team, who takes all the pains to, obviously first select the site who's presenting, address questions that are relevant to all of us, especially our pediatrics colleagues, to deal with difficult to treat TB clinics. I also want to thank the chair of our national task force, Dr. Bharadwaj, for his consistent participation and guidance, and Dr. Kabra sir, who would be guiding the team as well today. Of course, I'm not really aware of the case we are discussing. I'll also get to know as we go through this. But the team at AIMS has worked consistently, and with Dr. Kabra sir, we published quite a few papers along with Dr. Sangeeta as well, trying to deal with issues that bother all of us when dealing with small children, their diagnosis, their treatment, and all through the treatment, the issues that we all face. So over to you, Dr. Sangeeta, and the team that is presenting. Thank you again.
Thank you, Dr. Urvashi. So, back to Mika, please.
So we now move on to today's case presentation. Today's case presentation is by Department of Pediatrics, AIMS, Delhi. And over to you, Dr. Srishel, for your case.
Thank you, ma'am. Good afternoon, sir. I thank NITRD for providing the opportunity to present the case. Are my slides visible, ma'am?
On the slideshow,
Yes.
please. Yes.
Yeah. Okay. Thank you, ma'am. Here I am presenting an interesting case of MDR-TB, which went through a prolonged stormy course. So here I am presenting a Master P, who is a 14-year-old male resident of Chandosi in Uttar Pradesh. He came to us with a presenting complaint of a swelling in a lower back since 24 months and a swelling in the right inguinal area since last 6 months. Coming to history of presenting illness through a timeline, the symptoms started from April, May of June 2022, where initially started with a swelling in the back and fever. The swelling in the back was of our lower back, which was initially a small, which gradually increased over next 2 months. This swelling was also associated with fever, which was initially mild to moderate degree, more in the evening time, and also responding to initially with oral medications. Since as the symptoms continued for nearly 1 to 1.5 months and which was not recurring with a local treatment, and also associated with some gait abnormality, which is making child difficult to walk. So they went to a orthopedician where seeing the prolonged course and fever, they did a MON2 test, which was positive. Hence, a poor response to initial medications and persistent symptoms end up swelling in the back and a MON2 positivity and a progressive gait abnormality. The child has been started on the first line anti-tubercular drugs. The exact details of the drugs were not available, but the child was initially started with the anti-tubercular therapy of one year. So since it's a bony tuberculosis, from June 2022 to June 2023, child was started with a first line medications. But as the child continued to take the drugs, the symptoms kept on persisting. Though there's a gradual reduction in the size of the swelling, the gait abnormality persisted. And seeing this persistent gait abnormality and swelling, the physician who was initially treating also decided to continue anti-tubercular drugs for another 6 months. So, but here also though the physician has asked them to take the drugs from government facility, the patients kept purchasing it from outside. Hence, the exact details of the drugs, dosage, comments, and not available. Following this, at the end of 1.5 years, in October 2023, the child developed an inguinal swelling on the right side, which was gradually increasing and kept increasing over next 15 days, for which they approached to the same surgeon, orthopedician, who advised an incision drainage of the swelling. Here, what they noticed is, since the child is not having any fever or a cough or any other symptoms, they just assumed it as a abscess and just drained it. And here also, child was not sent for any other investigations along with the draining. Though the bacterial culture was sent here, it was negative, not suggestive of any growth. The swelling, inguinal swelling, reduced over next 1 to 2 months, again to recur in the January. Here, at the end of January, the child has already finished the antitubercular therapy of nearly 1.5 years. Hence, and they were advised to stop the antitubercular drugs. What here they noticed the swelling which was recurred again in the right inguinal swelling, and it was progressively increasing. Hence, here the incision drainage was done again here. At this time, they were sent for this gene expert from that pus, which was suggestive of rifampicin resistance. Gene expert was positive and rifampicin resistance was present. Hence, the drugs were modified as per the rifampicin and isoniazid were removed, and it was replaced by leoflox and linezolid along with pyrazinamide and ethambutol were continued. And these drugs, the dosage of these drugs were available to us prescription. They were at the adequate duration, and they were asked to continue for next 3 to 4 months. Since following starting these therapies, even though the swelling in the back persisted along with some amount of pain and the swelling, there was not much change in the size of the inguinal swellings. The parents decided to come to the AIMS. So child approached to AIMS New Delhi in May 2024. Negative history. Hello?
Continue.
Yes. Negative history, there was no history of any suggestion of cough, hurried breathing, hemoptysis, or seizures, vomiting, or a blurring vision, or any skin rash. There is a history of contact with TB. There is a 15-year-old child who was supposed to be the relative, which was supposed to be pulmonary TB, diagnosed at Mehroli in 2015, it is actually, and which was diagnosed as MDR-TB and expired within 1 year of diagnosis with respiratory illnesses. This index child was 5 years then, and father used to leave him in their house whenever they are going out for their purpose of job, as they were teachers and social medical social worker. Mother was a social worker. So he was the only single child. The father is a teacher. He used to take tuitions, and the mother is a social worker in the health and family welfare. Dietary history: since last 1 to 2 years, child was a poor eater. It was nearly protein deficit was of 10 gram and caloric deficits of 700 calories. Immunization history was adequate. Received all vaccinations up to the age of 5 years, and BC scar is present. Developmental history was normal. So in summary, we have a 14-year-old male child presented with initial symptoms of back of swelling, persistent fever, which recovered, and limping. He was diagnosed with TB and received first-line antituberculosis therapy for 18 months, showing a good response initially. However, he later experienced a recurrence of back swelling along with the development of new inguinal abscess. The microbiological testing confirmed rifampicin-resistant TB. He was switched to a modified ATT regimen but showed only a partial response. He has undergone drainage of spinal abscess once and an inguinal abscess twice. Any clarifications up till here?
So, Dr. Dulika, we have discussion right now, or we should finish the case first and then discussion?
I think, sir, it would be better if we do the case first and discussion later.
Okay, Dr. Shishal, then continue.
Yes. So after here, a possibility we have is the child, we have already the proven shown report of rifampicin-resistant TB predominantly involving the spine with possibly a psoas abscess or a involvement of spine with a inguinal lymphadenitis or lymph node tuberculosis. And risk factors for DR-TB we have is a contact who is documented DR-TB who dies in the past, though definitely we have means by definition it's a past 2 years, but significant history nearly 7 years, and the child was used to significant contact history was there. That contact history cannot be neglected. And the doubtful treatment history where initially for 1.5 year child has taken treatment, following that even the predominant drugs like INH and rifampicin have been omitted out, along with pyrazinamide and ethambutol have been continued. And second line drugs like levofloxacin and linezolid have been added. Though they have the important problem is the MGIT or a second line, first line or second line LP had not been done, and we don't know the drug sensitivity of the other drugs. Hence, by default, by default, it carries a label of MDR-TB or a defaulter. On general examination, child is weighing 38 kg with a z-score of -1, height of 161 with a z-score of 0.14 and a BMI of 14.66. On general examination, his vitals were most of them were normal: temperature 98, pulse rate 82, respiratory rate 20 beats per minute, and blood pressure of 110/70, CRT of less than 3 seconds, and SpO2 of 96% at room air. On general examination, mild pallor is present, no icterus, no cyanosis, no clubbing, and no lymphadenopathy at presently, except the right inguinal swelling. No edema, dehydration, or a scar present in the right inguinal area, and along with small scar present in the back of the or spine also. Head to toe examination, BCG scar present, skin scar survey is normal, and ear, nose, throat is also normal. Chest, respiratory system examination predominantly normal. Chest is bilateral symmetrical. On palpation, TVF, trachea central, apical impulse felt in the left fifth intercostal space. Percussion, resonant note, heard all over lung fields. On auscultation, vesicular breath sounds heard all over lung fields. Skeletal examination, there's a gibbous is present at L1, L2 area, spinous process. Kyphosis present, and a gait, which is limping gait, with scar present on the lower back with mild tenderness. On abdomen, normal in shape, non-tender, soft, no organomegaly, and no fluid thrill with shifting dullness. Bowl sounds present, and the scar present at the right inguinal area. Into investigations, apart from the previous investigations, most of the reports were blood investigations were normal, and most of them were lost. Only report they were having was the gene expert report with which they came to AIMS. The pus from the right inguinal lymph node, which was done on the January 2024, gene expert positive, and rifampicin resistance was detected with HIV negative. So this is the so far case, sir.
Any questions till this point from the audience?
Yeah, ma'am, one question. What was the respiratory examination, whether sputum was done when the ATT was started on the basis of MT test, sputum and or X-ray? And my second question is, patient had a gait abnormality. So what is the cause of this gait abnormality? Is he having any neuropathic symptoms also, or how gait is affected in this patient? Thank you.
The first thing is, child never had a respiratory symptoms, including cough or hurried breathing or respiratory distress. So sputum was never done. That's the one thing. And this gait abnormality, predominantly they were attributed to initially the pain following when initially started having fever and swelling, and it was predominantly related to pain. A pain at the local area, that is at the spine.
Okay. Any other extra pulmonary site like cervical lymph nodes involved, axillary lymph nodes involvement, any other extrapulmonary site which can be clinically examined? Is there any involvement?
No, sir. On history wise, also when the child was initially diagnosed, initially started an ATT, at that time also complaints were predominantly only fever, which was subsided after one and a half month to 2 months, and the swelling. Apart from this, there was no other significant complaint. Only next complaint is abnormal gait, which because of the pain. No other swelling anywhere else in the body. No history of any vomiting, altered sensorium, or any hemoptysis, or cough, or hematuria, or abdominal swellings.
Any signs of involvement of abdominal nodes, like a patient is having abdominal pain or cramps and low weight, low appetite?
Low
Any
appetite was
symptoms
there,
of
sir. It was continued. Appetite, the significant loss of appetite was there, and but occasionally he used to complain of abdominal pain, not like a continuous one. But on examination, we didn't find any tenderness or any hepatosplenomegaly.
And we also do not have any ultrasound abdomen to look for any lymph nodes, mesenteric nodes also, right?
No, no, sir. Later we
Thank
had we got a MRI. Means ultrasound we did, it was normal.
Okay, thank you.
Questions which you are asking, they're really important, because whenever you have a child, although with extrapulmonary TB involvement, always, despite the chest X-ray being normal, one should always get a sputum examination done. And the other thing is also to examine about the cervical lymph nodes. Your both questions are really relevant. So I think we proceed further.
Just one question, Dr. Kamal this side, ma'am. Do
Yes,
we
sir.
have any sensitivity report of the contact, drug sensitivity report?
A report is not there, sir, but this is on a retrospect. Actually, when the parents came to first time, they were refused of any contact with the TB case only. This is on retrospective follow-up examination. They were mentioned about this history of contact, which was on their relative. They're supposed to be relative, at which on their house these parents used to leave this kid. This
Because
kid
if the
was present
culture
in.
was sent, probably it will be available in the system. The program would have that report. The culture would be that.
Yes,
That can help because
the total duration of diagnosis to death was, as per father, it was 1 year, sir, and the child was died because of the respiratory illness, and he mentioned the word MDR-TB.
No, the question Dr. Kamal is asking, because these reports now they can be retrieved through the NICSHA ID. So that is what precisely Dr. Kamal is hinting at.
yes, man, it
Because
can give us lead in that sense
yeah,
because by the time we have cultures with this child, the
because
rest can help.
the child had already, the contact had already received MDR-TB treatment, although the outcome was not good. But the reports can be retrieved through the mobile number. So that could have been done. So these are the lessons which we learn from each other, AIMS team has done really a good job, but these are the lessons which we all, interact and we tend to learn. I think we go further.
Yes, ma'am. Yes, ma'am. Coming to X-rays, though child was diagnosed with TB or spot spine in 2022, we didn't have any X-rays of 2022. Only when the symptoms of the lymph node started, we have X-rays. That is October 23, where if we see the X-ray, we will be able to see there is a fusion of the L1 and L2 vertebrae with loss of intervertebral disc space, both in the lateral also. Here we can see there is a loss of intervertebral disc space along with fusion of the L1 and L2 vertebra. So this is in 30th January where the second lymph node was there. Second lymph node appeared and the gene export came positive. This is an X-ray of the Jan, which also findings were same almost. Even it's completely fused L1 and L2 vertebra with slightly protrusion into the spinal cord. And this is a chest X-ray which was taken just to rule out the intrathoracic abnormalities, which was normal. This is a MRI which was taken on just before coming to AIMS New Delhi. That is on 29/6/2024. This MRI we can see there is an paradiscal involvement of the L1 and L2 vertebra. Here we can have L1 and L2 vertebrae with intervertebral disc destruction, and there's a minimal enhancing prevertebral collection here. Here we can see the prevertebral collections. So with this, this is sufficient to make a diagnosis of at least an port spine, which was resistant, that is MDR-TB. MDR-TB, which is a port spine, and also other even lymph node TB also. And we'll be able to say at least the child has received inappropriate therapy or inadequate therapy, we can say, with inadequate drugs also. Because when it comes to MDR-TB, sir.
I request the host to mute the all presenters and Dr. Session will continue.
Yes, sir. So So there is a type of resistance. We have a rifampicin resistance is there, and there is a history of past treatment also is there, where nearly even present before coming to here, child has received significant amount of levofloxacin linezolid. So any second line drugs which are received more than a duration of more than 1 month also contributes to have a modified or individualized regimen for this child. And the type of the disease we will be able to say it's a significant, because here involvement is osteoarticular TB is there and inguinal TB. If it is an isolated inguinal TB, we will be able to say non-severe disease, and directly a 6 month or 9 month all 9 month all oral regimens can be given. But here we have a osteoarticular TB also, which is against the adopting the all oral short course regimen. The treatment plan we need to be individualized. The curated regimen has to be made. Notification has to be made, and the specified treatment has to be made for this child, along with the family screening, with investigations involving the to rule out involvement of other like CNS or intrathoracic or any other joint involvement also. So coming to DRTB, as per WHO consolidated guidelines on the module 4, here WHO divides DRTB into 5 classes, in which first class we have isoniazid resistant, second class we have isolated rifampicin resistance, and third class we have a multi-drug resistant, that is rifampicin or resistant to both rifampicin and isoniazid one. The fourth group, which is very important, where it is a pre-extensively drug resistant TB, where child will be having resistant to isoniazid, rifampicin, and a fluoroquinolone also. In the fifth group, we have extensive drug resistant TB, where the child will be having resistant to rifampicin, isoniazid, fluoroquinolones, and one of the drugs with group A drugs. That is group A mainly the linezolid, levofloxacin, and the bedaquiline. So if any of the drugs, resistant will qualify for extensive drug resistance. These classifications are mainly needed to decide about the either all oral regimens, all short regimens, or any injectable drugs or second line drugs to be included or not. And who is a DRTB suspect? A DRTB suspect is a contact with a person with a confirmed DRTB, or a contact with a person with presumed DRTB who is failed treatment, recurrence TB, or recently died from the TB. A child or adolescent with a TB not responding to first line treatment after 2 to 3 months of despite good adherence. And iris is also not considered likely in a child with HIV or ART. The child or adolescent previously treated for TB, especially within past 12 months, presents with recurrence of a disease also qualifies for a DRTB. And a contact investigations and screening of children in contact with infectious MDR or rifampicin resistant TB sources is essential for the rapid diagnosis and prompt initiation of the treatment. And apart from, there's a clear guidelines as per WHO recent guidelines of 2022. There is a all clear-cut guidelines for all oral 9 months regimen or all oral long regimens. But apart from that, because directly the patient, like in our case, we can't fit him in either all course 9 regimen or all course longer regimen, as child has already received the modified ATT in the form of receiving levofloxacin and linezolid. So we need to be build a individualized regimen for this kind of children, where omitting the drugs which are not responding before, or a resistance if they are drugs which are resistant to the already used drugs. We need to omit those drugs and replace with the group C drugs. Coming to groups, the WHO has given the different groups in a resistant TB, where group A contains the levofloxacin or moxifloxacin, linezolid, and bedaquiline, and including all 3 drugs is a must whenever building a regimen. And drugs from group B, where clofazimine or a cycloserine or terlidazine is there. So we need to include any one of the drugs in the regimen if all the 3 drugs from the group B are involved. If any one of the drug is not involved included from here because of the resistance, we need to involve both the drugs from the group B. And to make a regimen complete, we need to have at least to complete a regimen, we need to make at least 5 to 6 drugs. So apart from these 3 plus 2 drugs, we need to add 1 or 2 drugs from the group C. And there is a role of pretomanid. The pretomanid is already Presently, in the BPAL regimen, presently predominant is not approved for the children less than 15 years. And the coming to regimens, which was proposed by the WHO in 2022 update, a new regimen which contains a 6-month bedaquiline, protomanid linezolid or moxifloxacin, called short form called as BPAL or BPAL-M regimen for MDR or rifampicin regimen TB with and pre-XDR TB. Presently, this regimen is not available for children less than 15 years because of the safety and efficacy of the protomanid was not established in the children less than 15 years. Presently, we have an option of 9-month all oral regimen or a 18-month longer regimens for MDR-TB. We need to know what are the conditions which fits for or the conditions which fits for the all oral short regimen, that is 9-month regimens, which we are going to see. So the 6-month regimen which I mentioned, there is a modification for children's also is there. The WHO suggests the use of 6-month treatment regimen composed of bedaquiline, delamanid, linezolid, levofloxacin, and clofazimine in MDR rifampicin resistant TB patients with or without fluoroquine resistance, and can be effectively and safely used in the eligible patients with MDR TB and pre-XDR TB regardless of their HIV status. Who are eligible for this regimen? The people with MDR TB or rifampicin resistant TB or pre-XDR TB who are not eligible for BPAL regimen. So all our pediatric cases are eligible, but that's not an end. Here, the people with diagnosed with pulmonary TB, including children, adolescents, people living with HIV, pregnant and breastfeeding women, and the children, adolescents who do not have the bacterial conformation of TB or resistant patterns, but who do have a high likelihood of MDR TB in combination with the history of contact with TB, and all forms of extrapulmonary TB except TB involving, that is a complicated, all forms of TB involving CNS, osteoarticular or disseminated forms on a TB with a multi-organ. In these cases, we can't use this 6-month regimen. So only cases where we can use 6-month regimen is simple extrapulmonary TB, or a intrathoracic TB which is not causing respiratory distress or airway compromise. So in summary, we have regimens where 6-month regimen BPAL-M or BPAL-L, which is not yet approved for children less than 14 years. And
skip this and continue case.
Okay. So before starting the regimen, we got the baseline investigations where hemoglobin was 10, total counts was 8,090, neutrophil 73, lymphocyte 21. It was predominantly normal. LFT, ALT, AST were 21 and 17. Bilirubin were normal. Total protein and albumin were 7.5 and 5. RBS was normal. T3, T4, TSH were normal, and ECG was normal. With QT and roll was also normal. The child was started on all oral longer regimen, 18 months. And one drawback here was we didn't have an MGIT, which was not sent. So with this previous history, we started an all oral long regimen of 18 months, and date of starting regimen was 7/6/2024. Drugs included were bedaquiline, which is having best safety and efficacy with the present studies. I will going to share this study. Bedaquiline, levofloxacin, linezolid, clofazimine, cycloserine, along with pyridoxine were started. And the child was planned for follow-up after 4 weeks. So at the end of 3 weeks, child visited back again with a history of size of the lymph nodes started reducing, appetite improved, weight was same, no pain abdomen and vomiting, but he was complaining of pain or tingling sensation in the bilateral feet with reduced sensation, that is glove and stocking type, limping while walking. His bowel and bladder habits were normal. On evaluation, his drug dose was adequate. He was taking drugs from the government facility. His compliance was good. His weight was 37 kg. Systemic examinations was normal. But on a CNS examination, his DTR were brisk, both upper and lower limb bilaterally, and reduced crude touch sensation on the dorsum of the feet bilaterally. Power was more than 4/5 in left and the 3/5 in the right lower limb, probably related to even pain also. So here we can think, though the child is clinically improving, his symptoms are reducing, the general condition is improved, but he is having localized finding in the lower limb. Though the possibility we kept were either the primary disease progression, which was unlikely, hence their possibility may be being the nerve compression or the vertebral collapse is worsened and compressing the spinal cord, or a drug related maybe neuropathy And if it is yes, what are the drugs which can cause the neuropathy? So coming to seeing the adverse effects with respect to drug-resistant TB, here the predominant drugs used in this child and commonly used are this levofloxacin. A list has been given, of which levofloxacin predominant drugs has been displayed here. So, and here if you see, child was having receiving levofloxacin since last 6 months. Child is receiving. So he was not having any of these symptoms before the starting our new regimen. So the predominant side effects being levofloxacin with sleep disturbance, GI disturbance, arthritis, arthralgia, headache. So we thought of its the present symptoms may be unlikely because of the levofloxacin. Bedaquiline, which also has side effects of nausea, QT prolongation, liver hepatotoxicity, neuropathy, toxic nephropathies, arthralgia, increased LDH, cardiotoxicity, AV blocks. So since the bedaquiline we added recently, it's only child has received for 3 weeks. So the possibility of side effects being because of bedaquiline was more in high chances. Other drug, delaminate, protamide, we didn't give. Linezolid was a possibility, peripheral neuropathy, optic neuritis, and myelosuppression, though his CBC was not suggestive of any myelosuppression. The other drugs like clofazimine, skin discoloration, none of these were there. Child was receiving cyclosporine, neurological and psychological adverse effects with severe depression and suicidal ideation were also there. So since we added a bedaquiline here, a few details about the just 1 minute. The safety and efficacy of the bedaquiline, which was recently published in BMJ. This is in 2022, where they have studied the safety, efficacy, and utilization of the emergence of resistance following the treatment of multi-drug resistant tuberculosis in patients with retrospective cohort analysis. This is the largest database, nearly of 5,900 patients of MDR-TB, where they have divided the patients into bedaquiline, those who are on bedaquiline and those who are not on the bedaquiline. So in which they have studied, they've included all MDR-TB, pre-XDR and XDR-TB, where they compared the side effects and adverse effect profile among the two groups. Where what they noticed is in the both nearly 3,700 were bedaquiline group and 2,200 were non-bedaquiline group. So
skip this review, just first finish the case. Okay.
Yes. So success rate was highest with bedaquiline compared with the non-bedaquiline group. And these are the adverse effects where predominant were vomiting, arthralgia, rash, hypothyroidism, peripheral neuropathy, ototoxicity, and pain. This is the with respect to common adverse effect management with GI distress. We can most of the times we need to discontinue the offending drug and treat the electrolyte abnormalities like in QT prolongation. So coming to investigations, when we sent investigations of CBC, B12, folate, MRI spine to rule out the compression or ongoing active disease, audiometry, ophthalmologic evaluation, CBC. So at the end of, we got the reports. We asked them to. So it took nearly 1 week for the reports to come, including MRI. So symptoms persist and the drug doses were adequate, compliance good, and neurological same as before. His contrast enhanced MRI were showing pre-vertebral collection in L1, L2 area and irregularity in the vertebral margin suggestive of healing but active lesions. His B12 level were less than 100, which was significantly reduced. Folate were normal and QTC was normal and vitamin D is also normal. Hence, which was the B12 deficiency or drug-induced peripheral neuropathy was a main first possibility. And this repeat MRI was also suggestive of the healing, but active lesion, but it was healing compared to the previous lesion. And MRI brain also was done, which was normal. In summary, the predominant neuropathy signs, spine MRI showing signs of healing, brain MRI is normal, and reduced vitamin B12 levels. So coming to modifications, with these reports, we deferred the injection. The drugs like linezolid, cyclosporine, and bedaquiline all were causing peripheral neuropathy. We continued levofloxacin, clofazimine, and pyridoxine. And for the part of neuropathy, we gave injection neurobion 1 milligram once daily for 7 days. And pediatric neuro opinion for nerve conduction velocity was asked. On follow, after 8 weeks of starting 18 over the lower limbs and no distal muscle weakness. His blood sugars were normal. B12 were 275, which was increased compared to before. Folate were normal. QTC was 392 and CBC was normal. The impression, the resolving neuropathy. And bedaquiline, hence bedaquiline was restarted here because we have stopped the three drugs and we can't add it all together. So since bedaquiline is an important drug, we wanted to give. So we started bedaquiline first. So after 10 weeks, so there was a reduced pricking sensation and reduced pricking, and there's occasional pain in the knee and there is a vomiting. His nerve conduction velocity was normal and QTC was also normal. Since child was normal, so we decided to add the one cycloserine also as a second drug, and neurobion was continued. At the end of 12 weeks, pain increased in the right knee, the burning sensation in extremities, and pain abdomen occasionally. No vomiting. Weight was 38 kg. This is, sorry for a typo. This is a 38 kg, and gait was, he was not able to squat still. His CBC was normal, QTC was also normal, and here also we thought of again, since child was having again symptoms of this nerve pain, it was decided to stop the bedaquiline. Rest other drugs were continued and followed up at 14 weeks, where right knee pain persists and burning sensation reduced. The pain abdomen persists and no vomiting. So here it was decided to start again the bedaquiline, linezolid, and to stop permanently if symptoms recurs. But after 18 weeks, when we reviewed, the symptoms improved. There was a new onset rash. A child was not complaining, which was there on examination. And the drugs, bedaquiline, clofazimine, cycloserine, linezolid, and levofloxacin are all child was able to take successfully. Weight was increased of the weight gain of nearly 1 kg, that is 39 kg, and nerve conduction velocity was done again, which was normal. The rash attributed to clofazimine, we didn't stop the drug. Presently, the minimal numbness present, no pain, rash was subsided, gait normal, inguinal lymph nodes, and only scarring present, no active nodes, and child is being followed at neurology for the neuropathy or pain. Neuropathy is subsided, pain in the joints were there, for which child is being followed at neurology. Bedaquiline is stopped this month end, and it will be finishing the 6 month of bedaquiline, and continuous phase will be continued till the December of this 2025 with other drugs. Physiotherapy will be continued. So take-home message will be the management of MDR-TB is a complex and a lengthy treatment regimen. So consistency and compliance need to be checked while taking the drugs. We need to be aware about the different side effects profile of all the drugs, because nearly 5 to 6 drugs child will be taking, and decision on to decide about which is the offending drug is very, very critical. So we need to be decided, decision has to be taken. Limited drug options are there, because if even the resistance for bedaquiline is also noted in nearly 1.5% of the patients. So we need to be careful about the compliance of the drugs. Ensure patient adherence and diagnostic challenges and high cost of treatment. Though, of course, these drugs have been given with the government facility, but going to government facility itself is a problem in the patients. So they think it's one of the taboo. Once we go there, they may be socially segregated. And watch for resistance evolution is a priority for the physicians. Thank you.
Thank you, Dr. Srishel, for this very well worked up case. I would now invite questions from the house if you have any questions to ask.
Dr. Kamal, this side, just one question. How much pyridoxine was being given to this child?
Sir, sorry?
How much pyridoxine was being given with that MDR regime?
100 mg, sir.
Okay, because that is one thing which will cause neuropathy. Symptoms will be more or less alike. But 100 mg is good enough dose, but you can go up to 200, 300 with very severe manifestations. Thank you.
Yes.
So usually this NTB program provides the 100 milligram dosage for the DR-TB cases. It is as per the program.
My question is regarding the dose of linezolid. You mentioned that the linezolid was given at the dose of 600 milligram. So
Yes,
this
sir.
is a 14-year-old kid, and when the ATT was started, he was around less than 34 kg. So the dose, according to the guidelines, national guidelines, I'm not talking about the WHO, but according to the national guidelines, the dose is 450 milligram in this patient. So increased dose of linezolid puts the patient in risk of developing peripheral neuropathy, because in our experience, peripheral neuropathy is almost exclusively caused by linezolid. My second question is, my first was the dose of linezolid, which was 600. So whether it was, maybe that is the main reason. So my second question was, you said the nerve conduction velocity was normal, but it was subsequently done nerve conduction velocity. What was the initial nerve conduction velocity, and when did
Uh,
you did you perform that test, and what was the
yes,
report of that test?
yes, sir. With respect to linezolid, exactly you mentioned, sir, it may be a possibility. We'll check the dose. And with respect to second one, the nerve conduction velocity, though we asked at initial presentation, the slot was not there. So clinically, as we are, neuropathy was a strong possibility. We started Neurobion, and only first nerve conduction velocity was done nearly 2 weeks later. At that time, symptoms were less.
And that test was reported as normal.
Normal, yes, sir.
Okay. Thank you. Excellent case. Thank you.
I have a few questions to ask. I don't know. One is regarding the X-ray picture. Was it showing any compression of the spinal cord, because the DTRs were exaggerated?
There is no spinal cord compression, ma'am. We discussed with the radiologist. Though
Okay.
there is a intervertebral disc prolapse is there, and there is some anterior in X-ray, not in MRI it was there actually, but X-ray they were not suggestive of any compression.
Because linzolid causes peripheral neuropathies. What we expected is that the reflexes would go down, the sensations would go down, or there'll be tingling and pricking sensations. But
Yeah.
when the reflexes are exaggerated, we should always keep in mind compression. My other question is, did you send the sample initially at the outset when the patient came to you for the liquid culture, as well as the smear examination followed by first and second line LPA? Because those will guide us regarding the whether it is FQ sensitive or not, and the modifications in the regimen. So, what was the report of the lab, the culture DST?
Yes, ma'am. The diagnosis of rifampicin resistant TB was done in January 2024, and child came to us in June 2024. By the time he came to us, there was no obvious swelling at the back. Only gibbous was there, and the MRI was not suggestive of any collections. Very minimal paravertebral collection, which was not amenable to drainage, was there. And even inguinal nodes also, there was enlarged nodes, small enlarged nodes, but with scar tissue, not amenable for aspiration was there, ma'am. So that's the reason we didn't plan any procedure. We directly moved to, based on the previous report, we shifted to the drug DRTB regimen.
And what about the SWA sepsis?
Ma'am?
The SWA sepsis. You said there was a SWA sepsis.
It was there in the during the early course of the disease, ma'am, which was drained by the physician, which was when they started the first line ATT. When he came to us, we looked for it, but it was not the MRI, the first MRI which I shown, which was not suggestive of any significant collection, or not collections which was not amenable to drainage.
So, on your examination, there was no site which was accessible to send the universal DST, the culture.
No, ma'am.
Okay, because that is very, very important, because
Yes, ma'am.
this needs to go that we need to do a very good, thorough clinical examination to see the sites, because the maximum chances of picking up the organism are at the start of the treatment. And what about the fundus examination?
It was done, ma'am. Even the orbit MRI also was done. I have not shared the images. If you
I'm talking of fundus examination, because in the pre-treatment evaluation, whenever we are starting linzolid,
yes.
we always get a fundus examination done.
Yes, ma'am. It was normal, ma'am. No signs of any raised ICT or any intraocular tension.
So, regarding the stoppage of the drugs, bedaquiline, in my experience, it hardly causes neurotoxicity, although you have managed the case very well. But what needed to be done was to stop, to withhold linzolid as well as cycloserine, and to start pregabalin or gabapentin. This is what we do in our clinical practice over here, because bedaquiline hardly causes. Bedaquiline more is the cardiotoxicity, but even for cardiotoxicity, now there's plenty of evidence which says that bedaquiline is comparatively safe. And the cardiotoxicity which we were so much apprehensive about is more due to clofazimine. And for the information of the House, I would like to say regarding the development of the symptoms, the toxicity, the adverse drug effects due to linzolid, the myelosuppression and the peripheral neuropathy. Myelosuppression, the chances of the child going into myelosuppression are less if you build up the hemoglobin more than 10 right initially, like was in your case. Your initial hemoglobin was 10 and above, so that was one of the reasons the child passed through this phase of, not going into myelosuppression. And the other thing is that myelosuppression occurs earlier by 1 month. 4 to 5 weeks is the time of myelosuppression. Anything less than 10% of the initial is considered, to keep a watch on the child. And the peripheral neuropathy develops late. That is by 11 to 14 weeks due to linzolid. And if there is optic peripheral neuropathy, that means optic neuritis or grade 4 or 5 peripheral neuropathy, then you should never reintroduce linzolid.
Okay.
My last question to you is regarding your gap in the bedaquiline, because you with one or two times the bedaquiline had to be withheld. So the time, that is also very important.
Yes, ma'am.
If the time gap occurs in the initial daily phase, that is initial 2 weeks, but when was the time gap?
Now, first time it was after 3 weeks, ma'am, and second time it was after 2 weeks.
No. I'm asking, was the gap the time onset when the BDQ regimen is started? At what time the bedaquiline had to be stopped?
After 3 weeks of starting
Okay, so you had already completed the intensive phase. That is, the daily dose
Yes,
had already been completed.
Yes,
So that's another message. Once the daily dose has been completed, then you don't need to repeat the daily dose.
Okay.
Now the continuation gap which you have had for bedaquiline, you will have to, because you stopped 3 major drugs in between. So in this case, maybe you will have to extend the regimen, further to a maximum of 20 weeks, 20 months, because there has been a gap in the regimen, and it's a severe form of disease because there is osteoarticular involvement with the spine as well as the lymph nodes. So this is the only thing which I would like to suggest over here. And what about the HIV and the blood sugar? I mean, I'm sure you must have done those.
Yeah, ma'am. I have mentioned it, ma'am. HIV is negative and blood sugar is it's
because we need to take care of these comorbidities also. Yeah, but very nice presentation and a case which gives so many messages. I mean, I would like to now ask Dr. Kabra to come in, and Dr. Jat to give their, expressions on this case.
Thank you, Dr. Sangeeta. Madam, thanks for asking me to give some comment. The major learning point from this case is that if you have a fresh case, then you should be trying to document AFB or TB from all the possible sites that it was discussed. Even if it is a EPTB, X-ray is normal, try to do a gastric aspirate specifically in such situation. Second thing is that though it was almost 7 years ago, there was a history of contact with TB. We should try to get the DST of the contact person. Important lesson which we learned is that the patient is getting some inadequate treatment, but he is showing some improvement. and there is no possibility of getting a fresh sample or documentation of a TB. In such a situation, we should optimize the treatment, follow up, and if there is a failure or recurrence, we try to keep a possibility that at that time we'll take out the sample. And the important challenges which we pediatrician face is one is that how to monitor such a patient to document whether he is improving or not improving, specifically if there is no respiratory or peripheral node involvement. Here it was predominantly involvement of the spine. So it was only a clinical and probably at the end radiology. The other thing is that other lesson learned is that when we start the treatment, the dose center will provide the medication and they decide about the doses. But pediatricians, as most of us are aware that it would be dose per kilogram. And we may not be surprised to see that the children are getting 750 milligram of 600 milligram of levofloxacin or this thing moxifloxacin. And same thing is regarding linezolid, very high doses. So we should try to reduce it. Only concern is that the pediatric formulations are not easily available. And the last thing is that we get intermittently some interruption of the treatment because of the non-availability. So we should try to keep informed the concerned people that there should not be any repeated interruption in the treatment. Thank you very much.
So you raised very pertinent and important points, no, that regarding the non-availability of the drugs in between and the dosages, they are started by the center, without consultation of the pediatrician. That led to this child receiving 600, which was the dose of 400 milligram. So very important.
Just ma'am, to add this one thing that in this case also, this is a frequent scenario that any pediatricians and some physicians, they diagnose even the drug sensitive TB or DRTB. They start the regime themselves. And most of the time, either the regime is inappropriate or doses are inappropriate. In this case, also this levofloxacin and lenalidomide is available in the market. Rest other drugs are not available in the market like clozapine, bedaquiline. So the child receives the 2 drugs only for this DRTB, 2 drugs second line only. It is main concern in that this treating the DRTBs. So all pediatricians should be aware that they should be properly referred to the dose center for starting the DRTB center, properly work up the cases before starting the DRTB, and then follow up and see the for side effects.
Another very important point which you have raised, because the child has received these 2 backbone drugs, the group A drugs, linezolid as well as levofloxacin, from a private practitioner as a 4-drug regimen. So that was precisely my reason asking that was the DST done right at the outset of starting the regimen from AIMS? Because these are the things which we are already facing, and these sessions, they are meant to let people know that MDR-TB regimens, they need, it's a proper protocol defined regimens. And as you shown in that chart, can we have that chart now? Because that is the chart which is very relevant now after the discussion. Can you show that chart which showed the different regimens for the benefit of the house?
Meanwhile, can I ask?
Dr. Sangeeta, in the meantime, I would like to touch upon a few points.
Yes, sir.
So, few things that I don't agree with. One, the presenter talked about a government setup and people are not willing to come because of stigma, whatever he meant. And I am of a very strong opinion that we all have to reduce the stigma. So, one, why is this the thought process of a government doctor? So, the effort that a government doctor should put in the care of a patient has to be then doubled or tripled, and probably the staff also have to change their attitude towards the patient, so that if you think this is the thought process of a patient, that needs to be changed.
Totally.
Few other things I agree with the DRTB, that the patient who's diagnosed with DRTB could come to a DRTB center, because as we are moving, I'm not really sure how many of the participants are aware that with a lot of effort at the end of program, we have rolled out the BPAL-M regimen. And of course, for now, it is for 14 years and years plus. We are also writing to the DCGI to permit us for usage of bedaquiline in younger age groups, smaller weight bands. We haven't yet gotten get a go ahead because of issues about data not being submitted by the company. We're also working on the laminate as well for younger age group. But the bottom line being a DRTB center is the first to get equipped from the National TB program. Hence, it may be a good idea to send the patient for care and referral. Not only that, for care under the program. Not only that, we are also equipping the laboratories which are affiliated with the DRTB center to do as much support as may be required for the sake of the patient's better care. For example, with the BPAL-M rolling out, we have equipped 25 laboratories across the country. This is just in the matter of last 1 or 2 months. We have equipped these laboratories to carry out DST to vidaquiline, pretomanid, linezolid, and moxifloxacin. That training has already been done, and they have started doing this work. So I agree there that the treatment could be initiated and also followed up in a DRTB center. Of course, our residents at AIIMS can also be posted with the DRTB center, like an ITRD or RBI-PMT, to learn to cater to DRTB patients. But I primarily said it for the sake of the drug regimens being easily available and the DRTB centers being more equipped and the labs also being more equipped. I had 1 or 2 more suggestions. The fact that the child was exposed to TB within the household in the past, I think no screening was done at that point, and I wonder if the screening of the household contacts was done by the treating physician at this point with this presentation. That is something that, excuse me, that is mandatory or highly recommended under the program, because children in this child's contact, if they are exposed, they need to be, first we need to rule out active TB, and then we need to move on to the TB preventive treatment. Another thing is whether the child was offered, nutrition support, for which we have had a major effort driving nutrition support to all TB patients. I'm not sure if all of that was taken care of. Nikshay Mitra has given to this family. Now we have moved on from November onwards. We have moved on to doubled NPY support, Nikshay Mitra support to be extended to the families of these patients. So I hope the state, I'm not sure if the STO or the STO team is here, but they will ensure, and we are supporting them with not only the Nikshay Mitra, NPY, with the amount that has been doubled as well. So these are essential components under the program, and if those are followed, then of course, the nutrition support in addition to the medicine will definitely benefit all the patients. So thank you.
Thank you, ma'am. Very, very pertinent suggestions, no? And also the food basket, and the treatment supporter. All these things, they are very important to be ensured.
Ma'am, I had a small query. I wanted to clarify the audience, because as we have seen in this case, the patient was started on drug sensitive TB on the basis of Montague's positivity and symptoms. So they didn't even attempt to confirm the patient microbiological confirmation. So how much importance should we give to Montague's positivity in cases of children, basically in children, in your opinion, ma'am?
You want me to answer? I think
Yes,
this
ma'am.
mostly. So Montague positive.
Sorry, before that, how was the DRTB diagnosis done? I probably missed that bit. How was the DRTB diagnosis done?
DRTB done was TB-NAT.
It was done 18 months later, ma'am, when the patient has received 18 months of drug-sensitive tuberculosis. And referred to AIIMS, they did the aspiration, and then CB-NAT came through, they did the DRTB diagnosis.
I thought they said culture was not done.
It was done.
Why was the same sample not sent for culture? The one that was...
It
So
was done in
Because the
Ahmedabad, no?
culture will give you the
that is
culture will give you the benefit of doing DST also.
Yes, ma'am.
so this is what I was asking
But
them.
now, of course, with the BPAL-M, I'll just one statement, Dr. Sangeeta. We are also rolling out targeted NGS in the sites where BPAL-M has been initiated. Because we had to find to start. So we have now trained all our sites for BPAL-M with targeted NGS, which will give us molecular drug resistance to extended second line drugs. But yeah, this question remains, why was culture not done?
Dr. Urvashi, I want to ask you about the status of the PathoDetect test and the Expert XDR, the launch.
No, so we have given you a better answer than XDR. XDR will give you only INH and fluoroquinolone. Amikacin you're not using. Targeted NGS will give you 15 drugs.
But that is available at limited.
But for the same cost. For the same cost. What is the question?
I mean, I'm asking about the status of implementation of Expert XDR. Because that
did you hear me? Can you hear me, Dr. Sangeeta? I am saying we have given you a better option. Targeted NGS is giving you 15 drugs resistance. XDR is only giving you 3 drugs. INH and fluoroquinolone over and above rifampicin. The other drugs are not helpful. Ethionamide, you only pick up 60%. So we decided to get a better technique. Could you hear me?
Yes.
And for PathoDetect, that doesn't apply here really, but we have rolled it out and we are slowly covering the country. We should be able to do that over the next few months. Doesn't really matter today here, but what we are offering is something much better and which no country has done till now.
Excellent.
But if the sample is not sent for culture or is not sent to the lab for further workup, then you will not get the results.
Ma'am, can I ask one more question?
Yes, please. Yes.
Ma'am, this question is for you, ma'am. Ma'am, this patient has near about completed the 6 months of his treatment, and after 6 months, his bedaquiline delaminate will be stopped, and linezolid will be tapered to 300 milligram. So in that case, patient will be left with 2 drugs, that is cycloserine and clofazimine, and half linezolid. According to guidelines, minimum 3 drugs should be continued in the CP phase of all oral longer regimen. So, and bearing in mind that this patient has TB in 2 different sites, one is inguinal, other is lymph node, other is in the spine. So, would it be any helpful for the case if we extend bedaquiline for 6 more months in this case, just to get the minimum 3 drugs in the CP guidelines moving?
No, the maximum extension of bedaquiline which is allowed is for 9 months. And that also in situations where there is limited availability of other drugs. So that is the reason I was telling them that because there have been gaps in the bedaquiline, bedaquiline had to be stopped twice. So at least, complete that and to extend the regimen. I've already said about that.
Sangeeta, he has a valid question. I would say I agree with him. In fact, that is the reason why we have not agreed to reducing the linezolid dosage to half in the BPAL-M. We are continuing till side effects come in and need to modify. We are also adding moxifloxacin because trials have shown that BPAL-M together will have less recurrences. So there is science behind it, and I agree with the question. So can you address that question? Why
Yes, ma'am.
Yeah.
Ma'am, may I?
Yes.
No, let Dr. Sangeeta answer and then possibly you could come in.
So in case, because over here, there's another problem. Suppose the child develops again peripheral neuropathy. Maybe we will have to withdraw linezolid. There could be a chance in such a situation, then we need to add 2 drugs, more 2 drugs in the continuation phase. That is pyrazinamide and ethinomide. They will have to be added in such a situation, because in the last you cannot add delaminate. The maximum duration is for 6 months. Bedaquiline maximum duration is for 9 months. And rest, as you said, clofazimine will go on, cycloserine will go on. Linzolid is a query because the child has already had grade 4 type of peripheral neuropathy. If this peripheral neuropathy recurs again, there is a real chance we'll have to stop linzolid. So continue bedaquiline for 9 months and clofazimine, cycloserine and add parazinamide and ethanamide. These are the guidelines under the program which we are following. No, I think I've answered your question. So if you need to, suppose you need to add the drugs where adequate quantity of drugs is not available in group A or group B in the intensive phase. In that situation, we add delaminid and amikacin. But in situations because delaminid and amikacin, they cannot be added in the last 12 months of the treatment. So in those situations where the child is already reached in the continuation phase, the possibilities which are available is that we need to continue bedaquiline for 9 months because that is already 6 to 9 BPAL M. So we can continue bedaquiline for 9 months. Safety data is already there along with clofazimine and cycloserine. And if linzolid has to be stopped about recurrence of the peripheral neuropathy again, or development of optic neuropathy, because optic neuropathy, even a single episode, is a total withdrawal or the stoppage of the drug. But for peripheral neuropathy, you can give a trial, and if there is a recurrence of grade 3 or 4, then you have to even stop linzolid. In such situations, add parazinamide and ethanamide in the continuation phase, as is in this child.
Thank you, ma'am.
Your question, Dr. Zohan?
I just want to add one thing actually in the pediatric TB. Once you start the drug regimen of the DR-TB treatment, the regular follow-up in the children is very important. Clinically and microbiologically follow-up are very important. In this case, actually in the follow-up cases, when the child comes into the follow-up, then the peripheral neuropathy just like tingling, and also as madam told that the myelosuppression is also very important. So CBC and other investigations and for neurologically and ophthalmic examination is very important in the case when you start the lenalidomide. I just want to add. Thank you.
Can we? I think they were already. Okay. Any other questions from anybody?
So with this, we come to the end of the 9th Pediatric TB Eco Clinic. I would like to thank the team from AIMS for highlighting the challenges we encounter in the management of drug-resistant TB, especially in pediatrics. I would now like to invite Dr. Ashok Bhardwaj for his closing remarks.
So thank you, madam. Thank you, Sangeeta. So we heard the discussion of this case. It was a wonderful case, quite informative. But I will not comment on this particular case. So I comment generally what Rushi also told. We are somehow compromising on the program guidelines. So we have got DRTB center in the country, too many. We cannot say that we are very less DRTB center, but these centers are not being utilized. So the patient, we have to gain the confidence of patient. Why stigma? I don't think so much of stigma can hinder the patient to avail government services. So program has done a lot for the people, as she told that the nutrition support, the increase from 500 to 1,000 rupees, it is a huge amount. And if we calculate the number of TB patients in the country, it is a huge amount. So we should conform to the program guidelines, whether they are children, whether they are adult. So Sangeeta madam, I discussed 2-3 states difficult to TB clinic. So there also I reiterated the same thing because program guidelines, program SOPs, they are compromised. So once they are compromised, then we will not be able to help the patient. So we should conform to the program guidelines and treat or manage that case, whether it is DSTB case or whether it is DITB case. So different guidelines for different type of cases. So we should conform to them. So thank you very much. Thank you very much for giving me a chance. Thank you.
Thank you, sir.
Thank you. So with this, we come to the end of the Pediatric TB Eco Clinic, and we have got a very important message after this clinic that we should abide by the national guidelines, which will help us to eliminate TB in future. So our next Eco Clinic is scheduled for the 3rd Tuesday of February. It will be hosted by BJMC Mumbai, Maharashtra. So see you all in our next Pediatric TB Eco Clinic. Till then, let's keep working towards eliminating TB.
Thank you, one and all. Thank you.